Hi, Chair Dexter, members of the committee. I'm happy to be here. For those of you who have not met me yet, my role is the Director of the Office of Advanced Analytics at OHSU. My PhD is in health economics, which might be a little relevant in the presentation I'm about to give. I'll admit that this presentation mostly has positive news in it, which a lot of people haven't associated with my presentations previously. I'll be sharing some slides. These slides will also be available today publicly. So every 2 weeks now, I do a briefing that's available on our website. And so those will go out later today. You guys get first look at it. And I'm working on the share here real quick. One more window. There we go. And I'll start off by saying the title I think is a lot more exciting than what we're able to say about the concepts. The idea of a pandemic or an endemic virus or spread of disease. Some of these are semantics in some ways, how we refer to things. I think it is pretty common right now, just in the public though, to try to be thinking about, hey, doesn't it feel like we're moving from one thing to the next? And I think there's certainly been a transition there that is happening. And I think Pat Allen showed actually a lot of the same data that I'll be showing. So I'll try to skip some of that. I'm glad I listened in on that. But we are certainly seeing a transition. And when we're going to talk about it being truly endemic, may still be a little ways away. And so here's here's a disclaimer to as I mentioned, my PhD is in health economics, which has been very helpful for understanding how humans respond to an infectious disease, but I'm not actually an infectious disease expert. I also not an expert in evolutionary biology, which would help you to understand things of, what other mutations are possible with this virus? That's not something I look at. But one thing I have been looking at is the patterns in the waves and understanding what that has entailed for us in terms of demands on our healthcare system and demands that that we're going to see going forward. In theory, a degree in health economics also, in addition to kind of trying to understand human behavior, which is really what it's about, it's a social science, it also could help you think about trade-offs that you're making, the kind of cost effectiveness type analyses. Now, I'm not going to go into those kind of trade-offs because those are kind of up to you in many ways. So I'm going to provide as much information as possible. But those are the big balancing act that I think everybody's thinking about is, has any of that calculus changed? And I don't think it's fully changed, but you'll see some data where it's certainly changing somewhat. And I think the things I would say about pandemic versus epidemic or endemic, just briefly, that, an epidemic is just one variant that's growing in a certain space. Pandemic is something new that goes across many different spaces. And then endemic is what we are really thinking about when there's a virus that's been there for a while and has continued to be present. And so, whenever these happen, ultimately what we've seen is each variant is kind of producing its own epidemic and sometimes a pandemic, right? And so each one of these can spread. It has new features. It has new things we're responding to, and it can go across the world. And so it's not really the same virus, in terms of, its impact. And so we're looking at each one. And so far, they've been similar enough that if you've been exposed to one, either really the vaccine that we designed around the original virus or the previous infection, it's pretty good at preventing subsequent severe disease. That's actually one pattern. But one of the patterns that broke just recently was that we weren't able to prevent infection as well. And so that became really evident with Omicron, is that while the vaccine was really good at preventing infection with Delta, it really didn't do much for preventing infection during Omicron. And that really fueled an explosive growth in an infection, which actually ended up probably not only infecting vaccinated people, but also unvaccinated people who may have been surrounded by vaccinated people. And so that's been a real change. And I think being able to note when the dynamics have changed in this is pretty important. So while prevention of infection really changed with the most recent with Omicron, and I'll refer to the two waves as BA1. That was the one that we had right over January, and then BA2, which is the current wave that we're in. And what we've seen is that that BA1 wave really, while there was a lot of infection in the vaccinated population, what we didn't see is a lot of severe disease. So that part of the kind of protection was still there. It also was preventing deaths in ways that we'd hoped for. So, you know, unfortunately, while the title is all about this, I'm mostly going to revert to the things that I do know about, which are going to be talking about some of the metrics that we have, my typical 2 or 3 month forecast, show you some of the data there. And I do have some unique data that you probably haven't seen that I think will be helpful. So I think that what I wanted to talk about a little bit is the burden of the disease and our metrics of that. And so I'm showing you four charts here that are kind of, you know, I think each relevant series over time. And if you could see the scale on the bottom, it starts way back in October. Each one has the same scale, October of 2020. So these data don't go back to the beginning, and they end about a week or so ago. And the first one is probably the one you haven't seen, which is the percent of people who indicate having symptoms of COVID. And it's actually a slightly refined definition, which is influenza-like illness, which is fever with either cough or sore throat. And what we see here is that in Oregon, these data are all for Oregon. And what we can see is the symptom level is extremely high right now. It is nearly as high as it was during the BA1 wave. And that's relevant because if we move over to the case counts, you'll see here in this next chart, the case counts are much lower than during the BA1 wave. And so as Pat Allen was mentioning, that is indicative of that much lower testing rate that we think is happening and is evident. Now, where am I getting the symptom data? These are surveys that go out actually via Facebook. They're weighted to approximate the actual population, not just Facebook users. And it's really asking, hey, have you had any symptoms of these types? And when we start losing our ability to measure things through positive cases or even in the hospital census, you know, I think many times you'll have heard me say the hospital census is my favorite metric. And that was the case because we knew that it represented some severity. We knew that we weren't going to miss any cases. If you showed up at the hospital, we were going to test you for COVID, and we would find out. But what ended up happening during Omicron is we had a much higher incidental rate. That meant the number was a little bit higher than the real severity, and that's because it was so prevalent across Oregon that just randomly, if you took a person who had a trauma or some other event, they might have COVID too. And so it really wasn't why they were there. And so, you know, I'd really banked on census as being my favorite metric for a long time, but now I've been moving towards, all right, let's look at some of these other ways that we could think about it. And symptoms is one. Now, the bad news about this metric, which I do like, is that the survey has been unfunded, and they're stopping at the end of June. So we may not get a lot more data out of this. I'm hoping that we'll find other ways to collect similar information about people just reporting symptoms, because that's a nice way to have a kind of a real-time measure. And then the last measure down here in the lower corner is deaths. And, you know, in many ways, this is the big outcome that we really are tracking. And you can see that's having a nice shape, which is we had a big wave during Delta. We had a smaller wave during BA1, and we're getting a very small wave during BA2. And so, you know, when I'm thinking about positive news, that's what I'm looking at, is seeing that our number of deaths, and certainly deaths per symptom, if you want to calculate that, is really low. And so this is based on what we've seen with Omicron. Now, long term, what do we think? Unfortunately, we can only know as much as the variants that exist. And so the other one that's on the horizon is BA4, BA5. I'll talk a little bit about that. But for the most part, we don't know what can happen next. So Delta already gave us one curveball. Omicron kind of gave us a different kind of curveball. Most of those things had actually been predicted as possible by evolutionary biologists. So we thought that there was a chance that you could get certainly a more transmissible version. What was interesting about Delta, it was actually more severe as well. And that is a little atypical. Usually you wouldn't expect a new variant to be more severe in terms of creating greater hospitalization. And that's really what we did see there. Omicron was more typical in that it did find a way around the immunity, right? The immunity from vaccination or the immunity from previous infection. And that's the more typical route that we'll expect. I try to overlay all these so you could really see. I created an index so you can see that symptoms, the cases, the census, and the deaths. And they've all been I took those same data, just divided by their average value. And what you can see is that indeed symptom levels are high and higher than usual, but cases are lower on a relative basis. So is the hospital census, which we also know has a fair bit of incidental cases in it. And then deaths, of course, much lower and much less likely to have incidental deaths reported, right? So we know that those are reviewed, I think, by Dr. Seidlinger and others to ensure that the deaths that are being reported are really, related to COVID. Again, so other measure, and you already saw this today, is that if you're trying to really pick up on what's going on out there, what am I missing? Finding out if people are going to the ED is pretty important, because here now we're not talking about if you just happen to have COVID. You did have COVID, or you have symptoms of COVID, and it was bad enough that you had to go to the ED. So I think this reflects something new as well, or good data. And as you can see, those data are low again. Obviously most of my work is designed around producing a forecast. And so I thought I'd kind of show that pretty upfront and give you a sense of what we're seeing going forward. As you can see, I'm expecting a peak here, probably in the next week. That peak is shown at about 300 and, I think 319 or so. So just above where we are right now. So the black dots are the current levels. The red is the forecast. And you can see I'm expecting a peak and then a decline, but not down to zero. And that's in part because we do have additional variants that are growing. BA2.12.1 is one that is worth making note of, and then BA4/BA5, and those are two sets of variants, and I'll be working on building those more explicitly into the model soon. Part of the reason why it takes a little while is we really need to see how it behaves, and luckily we have not been the first place to get hit by any of these variants ever, and so I can cheat and just go look and see what's happening somewhere else. And that gives me a much better way to tell you when I'm sure something looks bad or not. I'd rather not just use pure math. I'd rather look at actual data that shows something is bad. And so, that's what this model ends up reflecting is, kind of triangulating across, a lot of data and then putting those into parameters that produce something that I think is pretty reasonable. And so I'm hoping our census will peak here soon, come back down a little ways, but not go to zero, and then start working on when the next wave is. The main consistency we've had is waves. And so if you were going to bet on another wave, I would say that's a good bet. We're going to have another wave. And even the time between them seems to be pretty steady. And so, these are things that we don't know for sure, but now the amplitude will be the issue. Is it going to be a big one that affects the census? Is it going to be one that only affects symptom levels? these are the things that we're going to be looking for. I'm going to skip ahead to a couple other slides that I have. Or perhaps, why don't I pause here and just because this is the kind of the main things I wanted to talk about, and see if we have a little, if Chair Dexter, if you have time for questions now. I have a lot of other slides that I can kind of reference in answers, but I think it might be useful to see if there's any kind of questions about what we have so far.
Great, thank you, Dr. Graven. So I will open it up for questions. I certainly want to understand, as we transition, what you were just saying about, we kind of know even the time lag between waves, and it looks like it's around 5 months, 4 to 5 months. As it becomes predictable is part of my understanding of what endemic is, that you can anticipate a wave and expect how you need to accommodate for it. So how do you see us best preparing for what we know is coming if we don't know, as you said, the amplitude of the waves, and is there anything that we can do to mitigate harm in our communities in that sort of preparation phase?
Yeah, I think, obviously the big things so far have been, we do know ways that we can slow it down when needed, right? And so the masking has worked. It worked in Oregon pretty significantly, I think, during the BA1 wave. So knowing what tools are most efficient at getting the result you want is pretty important. And I think we're learning on that. Closing down a whole bunch of businesses is probably the least efficient thing. And until we had a vaccine out there, that was something that unfortunately was on the table, because we were getting really bad outcomes with unvaccinated people getting this disease or getting this virus. So I think that's the other part, is obviously ultimately it's the vaccination level that drives your outcomes. And so I'd like to say, hey, let's be really responsive to this over time and see if we can knock down more waves. But the ultimate predictor has been your vaccination level. And so anything that you can do to promote that, and I know we talked about reaching a ceiling of sorts, finding ways to get that ceiling a little higher. There will be a new vaccine that we will need one day, and probably not as soon as fall. That will be a big difference. But that's the thing that really ended up changing our total number of deaths that we were going to experience from this. And so I think focusing on that is probably, as important as I can think of. There is good reason to believe that most, that the subsequent variants will probably be not more severe, but they're likely to keep spreading. And so I think those change in burden is kind of the next area for policy, and that really includes long COVID, which you're going to hear more about, and just figuring out which policies are best for missing time from work and school and all those types of things, because certainly this is going to be present. I don't have any reason to believe it's going to go away, and it looks like it will, because it's able to travel the globe so quickly and find ways to avoid previous immunity. It's going to continue to do that.
I'm going to take chair privilege and ask a follow-up before I call on Vice Chair Hayden. So at what point, knowing that the death rates have gone way down despite the increase in infectiousness, and we know that the vaccines haven't really prevented infectivity, that is my understanding from what I've seen and understood, I want to understand a little more what you're saying about the vaccinations, and I have my own bias about this and belief in it, but I want to call that out, because I think there's a lot of people who are confused about why are we still promoting vaccines if they don't prevent infections and people aren't dying as a result of the infection at the rates that we saw previously.
Yeah, I think the bad news is it's really hard to perpetually prevent infection. And so, I think we found that. I will say that our Earthmates in China are gonna discover that as well. which is that preventing this infection forever is going to be hard. And so if you're going to go and eventually get it, you want a weighted dice in your favor to figure out what your outcome is going to be. And that weighted dice is definitely vaccination, right? Eventually, we all know we're kind of taking our chance a little bit on this, but when you have that vaccine, it just makes your odds come up better every time. And so that's ultimately, you're going to have to probably roll a dice at one point. Now, there's a whole bunch of immunocompromised people who there's a good strategy for preventing them probably as much as you can from ever getting it. But for most people, it will probably find a way, and so figuring out how to make sure that roll of the dice is your best one is the key. And so, I'm hoping we get another good vaccine out there, but I definitely wouldn't want to roll one without it.
Excellent. Thank you. Vice Chair Hayden, please go ahead.
Yeah, thank you, Chair Dexter. Thank you for the presentation. I've had the honor to be on COVID here throughout the time that we've had this committee. Just wondering, in your opinion, we hear a lot about the vaccines and the long COVID and different terms and everything, and the policy and the reaction to that. What I don't hear a lot about in this committee is what the effects are on the other side of it, rather than just get out of the sterile clinical environment of, hey, this is coming or this new variant is coming. When do we start looking at the effect on our society more globally from some of the policies that we do, and will we ever start having those types of discussions in this type of environment? Meaning that, yes, there's detrimental things with the COVID variants that are coming, but there's also detrimental things on the other side of the equation, and you kind of equated to that or referenced that, I think, as rolling the dice. But my question is, when do we start taking a look at kind of the holistic effect on our society of this, including other factors than the variant itself? I have been on this committee for a long time and I continue to wait for that. I'd appreciate any response you might have.
Chair Dexter, I can respond to that.
Please, thanks.
Yeah, so, I think this is actually more my bread and butter in many ways as a health economist, is thinking about those trade-offs. And actually, there's been a fair bit of work about trying to understand what is the impact of, a business closure versus a school closure versus just wearing a mask, and some of the ways that we're preventing infection. And I think I kind of mentioned that, the reality is those are probably only good to prevent waves. But ultimately, you probably can't prevent it forever, right? And so I think recognizing that that the real answer is still vaccination, because if you're going to get infected, which we can prevent at times, but not indefinitely, then the vaccine becomes the real change in strategy. It's harmless. And so when you think about it from any optimal strategy perspective, without a cost that is, at all evident, then, except for to a very small group of people, it becomes your kind of optimal or dominant strategy. And what you're trying to do in the meantime then is try to minimize the impacts that we saw in the healthcare sector, which unfortunately in Oregon were really unique, right? We have the fewest beds per capita. There was a lot of prevention of infection we had to do during short-term periods in order to maintain access. And so, that's my own perspective of, if you're trying to think about the ultimate costs and trade-offs here, it's really the vaccine is the only thing that really changes your death rate over the long term. And so to the extent that you can prevent it for a while, and you can hope that the next variant is less severe. You can hope that the next vaccine is better. But given what we know now, that is still the dominant strategy.
Quick follow-up, Chair.
Please go ahead.
So thank you. I appreciate the fact that you brought up hospital bed capacity. So kind of my question is, why aren't we having discussions within this about the hospital bed capacity, referring to, our process that we go through for certificate of need in hospitals? is still fully in place in Oregon. There's been legislative conversations about, putting that on hold for a while. But those of us that would like to have that discussion can't even get that discussion, a matter through the legislature to discuss the certificate of need, let alone change it. And so my question is, when we're doing policies and Oregon has the least beds in the nations, when we're talking about all of the things that we want to do to tamp down these spikes, well, one of the things that we could have in a conversation is, how can we have the least beds? We don't talk about, we just say we've got the least beds in the nation. Why don't we ever talk about why we have the least beds in the nation and what policy led us to that point? So anyway, just, some out loud thinking there, that we kind of seem to be myopic in our focus on, just the vaccine, but not other policies that put us in the position, for example, of the least hospital beds in the nation, for example. So I don't know if you want to respond to that, but that's kind of the point that I'm making, that we're looking at one aspect of this, but not necessarily looking at significant policies that I believe potentially contributed to putting us in that position.
So I am just going to make very clear, Dr. Graven, that you are not on the hot seat for our discussions or policies. If you have a response, I'd certainly welcome it, but I also will respond. But please go ahead.
Yeah, obviously today I'm not here prepared to talk about that. Be happy to, be invited back if that's a discussion item.
Yeah, thank you. And I think, Vice Chair Hayden, that was part of my intention with having this conversation, is at what point do we start pivoting? We aren't looking at this like a flu epidemic or a flu wave at this time. And at what point do we start thinking about it differently? Or other viral illnesses. And so I think that is what we are hearing from our constituents in a lot of different sectors or places. And I did want to try to have that conversation. And I will make note that we should talk about hospital bed capacity and whether that should be rediscussed, considering the pressures that we did see on our system. Certainly in our hospital, we have had that exact discussion in the ICU when that was, felt very personally. We were wondering at what point that pressure should be decompressed. So I will put that on our agenda potentially for September. We will, if we're still meeting in September in this committee, I certainly hope we will. And Dr. Graven, I really appreciate your perspective and willingness to weather these questions. Rep. Moore Green, please go ahead.
Thank you so much, Chair Dexter. And Dr. Graven, thank you also for your presentation this morning. If I could just tag on to the conversation, I thought that one of the slides that Dr. Nolt presented earlier, and let me just change my screen so I can look at it. It was slide number 20 from hers. It was the indirect impacts of COVID-19 pandemic on children. And while the previous conversation just now has been on hospitals and the system itself, I think it's important that those indirect consequences somehow also get woven into the conversation that we have. I think the prolonged isolation and fear that has unfortunately been instilled in some of our very at-risk children, young kids, is being played out in a lot of the behavior that we're seeing in our schools at the moment. And so I would just like to add that to the mix, Chair Dexter. And my hope is that, well, my hope isn't that we're still in the pandemic, but based on what Director Allen shared in the Healthcare Committee, was that on Wednesday? Yeah, today's Friday, on Wednesday, that it doesn't appear that we will be out of the pandemic before year end, based on I guess decisions at the federal level. So here again, I don't hope that we meet, but I do think that, there is a place for us moving forward. So thank you for allowing me to make some comments.
Yeah, absolutely. And we'll have presentations from ODE and other educators, so we may be able to touch on some of the concerns, not directly today, but certainly they may have some responses. I think we have lots of ongoing room for discussion, so I appreciate the committee members raising questions for further conversation. We certainly want to have, balanced presentations. I always welcome your recommendations, so please send those along. The last thing, Dr. Graven, I was going to ask before we close, unless another question comes up, is you mentioned that the vaccines are very safe. And I think that there's a lot of concern in the community about VAERS data and other things. And so if you can just speak to the safety of vaccines and what makes you say that they are without risk would be really helpful.
Yeah, I mean, I didn't brush up on the numbers just, because it's a question here. But, I think the big thing with the vaccine is at this point, it's been tested throughout the world billions of times. And so it's rare that you get a chance to see that scale of a vaccine and be able to look at the results and be able to assess how frequent you're seeing complications. And, obviously they're being collected in different databases, not necessarily dependent on if the vaccine caused it. So I know when folks look to see, oh, did somebody have some adverse event after the vaccine? Well, of course, we're not following to, only some of those are found out to have been caused by the vaccine. And in fact, almost all the time, they're found out to be, things that happen ordinarily, right? And so that is for folks who aren't used to looking at data like that, that can be a little confusing. And because we're talking about kind of causal stuff. Did one thing cause another? And how do you look at data to determine what caused another thing? And it turns out you can make some real errors by just looking at frequencies after an event. And so I think that's what I know with my own family members have probably made that mistake at times. And so trying to kind of understand what data is being collected there. And then, yes, indeed, when you go look at the number of people who've had truly adverse events from the vaccine, it is so small compared to how many doses have been put out there that, you really couldn't be, you almost couldn't be more impressed with how the vaccine works.
Great, thank you. Rep. Green, is your hand up for another question, or is that, okay, no, that's fine. I just wanted to make sure I didn't skip you. Okay, wonderful. All right, thank you so much, Dr. Graven.